Welcome to this Step 2 review on preoperative and postoperative care test-taking strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will encounter on your board exam for surgical perioperative management. We will cover preoperative risk assessment, deep vein thrombosis prophylaxis, the classic postoperative fever workup, and wound healing complications. The goal is not to reteach the entire topic, but to help you recognize patterns and apply test-taking strategies so you can pick the right answer quickly and confidently. Make sure you have reviewed the surgery and internal medicine sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for preoperative risk assessment and postoperative complications. Second, we will apply specific test-taking strategies for postoperative fever, deep vein thrombosis, prophylaxis, and wound healing questions. Third, we will master the next best step question format that the boards love to use for perioperative management decisions. Before we dive in, make sure you have reviewed the surgery sections of first aid and your question bank. This video is designed to help you apply that foundational knowledge on test day, not replace it. Our first strategy is the preoperative risk assessment framework. When you see a question asking about preoperative evaluation, the boards are testing whether you can identify the major risk factors and know the next best step. For cardiac risk, look for buzzwords like recent myocardial infarction, decompensated heart failure, significant valvular disease, and unstable angina. The key concept tested is functional capacity measured in metabolic equivalents. If a patient can climb 2 flights of stairs or walk 4 blocks without symptoms, that is roughly 4 metabolic equivalents and generally acceptable for most surgeries. For pulmonary risk, the boards love questions about smoking history and obstructive lung disease. Remember that smoking cessation at least 8 weeks before surgery reduces pulmonary complications, and incentive spirometry is the most commonly tested intervention for preventing postoperative atelectasis and pneumonia. Review the perioperative medicine section in your board review resources for the full risk stratification algorithms. Strategy 2 is the postoperative fever timeline, and this is one of the most heavily tested frameworks on the boards. The classic mnemonic is the 5 Ws, and you absolutely must know this for exam day. In the first 1 to 2 days, think wind, which means atelectasis. This is the most common cause of early postoperative fever and is treated with incentive spirometry and early ambulation. On days 3 to 5, think water, meaning urinary tract infection, especially if a Foley catheter has been in place. On days 5 to 7, think walking, meaning deep vein thrombosis or pulmonary embolism. On day 7 and beyond, think wound infection with erythema, warmth, and drainage at the surgical site. And finally, think wonder drugs, meaning drug fever, which is a diagnosis of exclusion after you have ruled out the other causes. Review the surgery chapter on postoperative complications in your board review books for a deeper dive into this framework. Now let us talk about recognizing high-yield question stems. For preoperative cardiac risk, the classic stem gives you a patient with known heart disease who is scheduled for elective surgery. The question will give you clues about their functional capacity, any recent cardiac events, and the type of surgery. The boards want you to stratify that risk before clearing the patient. For postoperative fever, the key is matching the timeline to the 5 Ws. The question will tell you which postoperative day the fever develops, and then give you associated findings like decreased breath sounds for atelectasis, dysuria for urinary tract infection, calf tenderness for deep vein thrombosis, or wound erythema for surgical site infection. For wound complications, the stem gives you a patient with changes at the surgical site days to weeks after the operation. You need to differentiate between dehiscence, evisceration, seroma, and hematoma based on the description and timeline. Review the wound healing chapter in your surgical review resources for the full details. Here is our first practice question. Read through this carefully. We have a 68-year-old man with stable angina and diabetes who is scheduled for elective hip replacement. He can only walk 2 blocks before getting chest discomfort, and his last catheterization showed moderate 2-vessel disease. The question asks for the most appropriate next step in preoperative management. Take a moment to think about what you would choose before we walk through the answer on the next slide. Let us walk through this answer step by step. Step 1. Spot the pattern. We have an elderly male with stable angina, diabetes, and he is going for elective high-risk orthopedic surgery. His functional capacity is poor because he can only walk 2 blocks before developing chest discomfort. That puts him at less than 4 metabolic equivalents. Step 2. Apply the rule. The board rule is that when a patient has poor functional capacity and is undergoing elevated risk surgery, you need further cardiac testing before proceeding. Since this patient cannot exercise adequately, pharmacologic stress testing is the right choice. Step 3. Eliminate the wrong answers. Proceeding without further workup ignores his significant risk factors. Cancelling the surgery permanently is too extreme for a patient with stable disease. A resting echocardiogram does not tell you about cardiac function under stress conditions, which is what you need to know before surgery. The answer is C. Obtain a pharmacologic cardiac stress test. Review the perioperative cardiac risk assessment algorithm in your board review resources for the complete stepwise approach. Here is our next practice question. We have a 55-year-old woman who develops a fever on postoperative day 1 after an open cholecystectomy. She has mild shortness of breath and decreased breath sounds at the lung bases. The wound looks clean and intact. Think about what the most likely cause of her fever is, using the 5 Ws framework before we go to the answer walkthrough. Let us walk through this one. The key here is applying the 5 Ws timeline. Postoperative day 1 puts this squarely in the wind category, meaning atelectasis. The clinical findings support this, with decreased breath sounds at the lung bases and mild shortness of breath. Now let us eliminate the other choices. Urinary tract infection is the water category and typically presents on postoperative day 3 to 5, especially with an indwelling catheter. Wound infection is the wound category and does not appear until postoperative day 7 or later. Deep vein thrombosis is the walking category and usually presents day 5 to 7. The answer is C. Atelectasis. This is the most common cause of fever in the first 48 hours after surgery, and it happens because patients take shallow breaths due to pain and residual sedation. The treatment is incentive spirometry and early ambulation. Remember, on the boards, the timeline is your best friend for post-operative fever questions. Now let us cover deep vein thrombosis prophylaxis, which is heavily tested on the boards. There are 2 main categories you need to know. Mechanical prophylaxis includes intermittent pneumatic compression devices and graduated compression stockings. These are used for low-risk patients or when anticoagulation is contraindicated. The boards love testing this when a patient has active bleeding, recent hemorrhagic stroke, or severe thrombocytopenia. In those scenarios, mechanical prophylaxis alone is the correct answer. Chemical prophylaxis includes unfractionated heparin and low molecular weight heparin. Low molecular weight heparin is generally preferred for major orthopedic procedures like hip and knee replacement. The key testing points are when to start prophylaxis and which agent to use based on the type of surgery and the patient risk profile. Make sure you review the full venous thromboembolism risk stratification table in your surgical review resources. Here is a practice question on deep vein thrombosis prophylaxis. We have a 62-year-old man who just had an elective total knee replacement. He has hypertension and obesity as risk factors. He is recovering well on postoperative day 1 with no bleeding disorders or recent stroke. The question asks for the most appropriate venous thromboembolism prophylaxis. Think about what you would choose based on the type of surgery and his risk profile. Let us walk through this answer. Spot the classic pattern first. Total knee replacement is a major orthopedic surgery and carries one of the highest risks for venous thromboembolism. This patient also has additional risk factors including age over 60, obesity, and hypertension, and there are no contraindications to chemical prophylaxis. Now the key distinction: aspirin alone is simply not enough for a high-risk orthopedic patient. Intermittent pneumatic compression devices alone do not provide adequate protection for major joint replacement surgery. Warfarin with a goal international normalized ratio of 3 to 4 is supratherapeutic and would increase the bleeding risk unnecessarily. Low molecular weight heparin is the standard of care for deep vein thrombosis prophylaxis after major orthopedic surgery. The answer is B, low molecular weight heparin. Review the venous thromboembolism prophylaxis guidelines in your surgical and internal medicine review resources for the complete details. Our test-taking pearl for this video covers wound healing complications. There are 4 major wound complications the boards test. Dehiscence is separation of the wound layers and typically occurs 5 to 8 days after surgery. The classic presentation is a gush of serosanguinous fluid from the incision. Evisceration is when the abdominal contents protrude through the wound, and this is always a surgical emergency. The immediate management is to cover the exposed contents with moist, sterile saline dressings and rush the patient back to the operating room. Seroma is a collection of serous fluid under the skin, and hematoma is a collection of blood. Both are usually managed with observation unless they are large or symptomatic, in which case you drain them. The boards love testing risk factors for poor wound healing, including diabetes, malnutrition, especially low albumin, smoking, immunosuppression, and chronic steroid use. When you see a question stem describing serosanguinous drainage from a wound on postoperative day 5 to 8, think dehiscence. When you see abdominal contents visible in the wound, think evisceration, and remember it is always a surgical emergency. That wraps up our review of preoperative and postoperative care test-taking strategies for the boards. To summarize, make sure you are comfortable with preoperative cardiac and pulmonary risk assessment, the 5 Ws of postoperative fever, deep vein thrombosis, prophylaxis, guidelines for different surgical types, and wound healing complication recognition. For your study resources, review the surgery and internal medicine chapters in first aid and your question bank. Focus especially on the perioperative cardiac risk assessment algorithm, the 5 Ws mnemonic, venous thromboembolism prophylaxis guidelines, and wound healing complications. For expert one-on-one tutoring and residency advising, visit us at roadmap2residency.com. We have tutors who specialize in helping students master these high-yield surgical topics. If you found this video helpful, please like and subscribe to our channel for more board review content. Good luck on your exam, and we will see you in the next video.